axSpA is a chronic inflammatory condition that primarily affects the sacroiliac joints and spine. It's much more than just back pain. It's a systemic disease that can be easily misdiagnosed and mismanaged. The sacroiliac joints, where the spine connects to the pelvis, are often the first site of inflammation. This inflammation can spread to other parts of the spine over time. Let's look at the epidemiology of axial spondyloarthritis. This condition affects up to 1.5% of the global population, with symptoms typically beginning before the age of 45. Men and women are affected differently, with women often experiencing more peripheral symptoms and potentially facing longer diagnostic delays. On average, diagnosis is delayed by 6 to 8 years from symptom onset. A key genetic factor in axSpA is HLA-B27. This gene is present in about 90% of patients with radiographic axSpA. While 5 to 6% of the general population carries this gene, only 1 to 5% of HLA-B27 positive individuals will develop the disease, suggesting other factors are involved. The pathophysiology of axSpA centers around enthesitis, which is the inflammation of sites where tendons and ligaments insert into bone. These entheses are subject to mechanical stress, which can trigger an inflammatory response in genetically susceptible individuals. The inflammatory process in axSpA involves several key cytokines. TNF-alpha triggers production of interleukin-23, which then stimulates interleukin-17. This cytokine cascade drives the chronic inflammation characteristic of the disease. This persistent inflammation has several consequences. It can lead to bone erosion, particularly at the sacroiliac joints. Paradoxically, it also triggers new bone formation, creating bony outgrowths called syndesmophytes. Over time, these can bridge adjacent vertebrae, resulting in the characteristic bamboo spine seen in advanced cases. This X-ray shows the characteristic bamboo spine appearance in advanced axial spondyloarthritis. Note the syndesmophytes, bony growths that bridge adjacent vertebrae, creating the appearance of bamboo. These changes significantly reduce spinal mobility and can cause permanent disability if the disease is not properly managed. Recent research emphasizes the importance of recognizing axSpA early to prevent this progressive damage. Understanding the pathophysiology helps explain why targeting specific inflammatory pathways, such as TNF and IL-17, has been effective in treatment.
Let's examine the clinical presentation, diagnosis, and latest advances in axial spondyloarthritis management. Inflammatory back pain is a key symptom of axial spondyloarthritis. It typically has a gradual onset before age 45, with morning stiffness lasting over 30 minutes. Unlike mechanical back pain, inflammatory pain improves with activity, worsens with rest, and often wakes patients during the second half of the night. Patients with inflammatory back pain typically show a good response to nonsteroidal anti-inflammatory drugs. This comparison highlights the key differences between inflammatory and mechanical back pain. Axial spondyloarthritis extends beyond the spine with several extraarticular manifestations. These include acute anterior uveitis, which is inflammation of the eye, psoriasis, and inflammatory bowel disease. Patients may also experience enthesitis, commonly presenting as heel pain or Achilles tendinopathy, peripheral joint arthritis, and significant fatigue. Diagnosis of axial spondyloarthritis requires a comprehensive approach. The diagnostic approach includes a detailed clinical history and physical examination, followed by laboratory tests including HLA-B27 and inflammatory markers. Imaging is crucial, particularly MRI of the sacroiliac joints, which can detect inflammation before structural damage is visible on X-rays. While the assessment of Spondyloarthritis International Society classification criteria are valuable for research, they should not replace clinical judgment in diagnosis. This infographic illustrates the spectrum of axial spondyloarthritis from non-radiographic to radiographic forms. Management of axial spondyloarthritis includes both pharmacological and non-pharmacological approaches. Pharmacological treatments include NSAIDs as first-line therapy, followed by biologics such as TNF inhibitors and IL-17 inhibitors. Newer options include JAK inhibitors, which offer an oral alternative to injectable biologics. Non-pharmacological approaches are equally important, including regular exercise, physical therapy, postural training, and smoking cessation. Several important advances have recently emerged in axial spondyloarthritis management. The British Society for Rheumatology published updated treatment guidelines in 2025, incorporating new classes of biologic DMARDs, targeted synthetic DMARDs, and drug tapering strategies. A new blood test, the anti-14-3-eta multiplex test, aims to enable earlier and more accurate diagnoses of axial spondyloarthritis, complementing existing tools like CRP and HLA-B27 testing. Multidisciplinary care is essential for holistic management of axial spondyloarthritis. The rheumatologist coordinates care with multiple specialists, including physiotherapists, ophthalmologists for eye involvement, gastroenterologists for bowel disease, dermatologists for skin manifestations, pain specialists, and nurse specialists. Finally, the concept of difficult to treat axial spondyloarthritis is emerging as an important clinical consideration. Studies highlight a prevalence of difficult to treat axSpA of 19.5 to 28.3% in real world cohorts. Risk factors include peripheral arthritis, comorbidities, and female gender. The Assessment of Spondyloarthritis International Society has developed a preliminary definition of difficult to manage axSpA, encompassing treatment refractory cases and broader management challenges. These patients require personalized treatment strategies, with future directions emphasizing biomarker driven precision medicine approaches.